Thank you, Chair. You're now live streaming.
Thank you very much indeed. Good afternoon, everybody, and a very warm welcome to the July meeting of the Wye Valley Trust Board. We have, as usual, a busy agenda, so we will try and get through in time. But for information for colleagues and the members of the public, we have this morning had a very productive and varied morning workshop and lots of important topics that we have discussed face to face as a board before we move into the important business of public scrutiny and assurance of the services that we provide for the people of Herefordshire and Mid Powys. We have apologies today from our Chair, Russell Hardy, and Chief Executive, Glenn Burley. Colleagues who may not have joined before will know that with the expansion of the Foundation Group in August last year to 4 trusts, we have a new board cycle, and so I, as Deputy Chair for Wye Valley, chair once a quarter, very ably supported by our Managing Director, Jane Ives. Also apologies from Erica Herman and Nicola Twigg. I don't think there's any more apologies to note, are there, Lou? No, Lou is shaking.
Nothing.
Thank you. And for people who haven't met her, Lou Robinson, who has worked for the Trust for many years in a variety of roles, is our new Deputy Company Secretary and very ably supporting the board today. So thank you, Lou. Has anybody got any declarations of interest for this particular meeting? I will take silence as nothing to declare. So the minutes of the meeting held on the 6th of June, has anybody got any matters of accuracy that they would like to correct? Again, I'll take absence of digital hands as assent. Thank you very much, Val, who is our Executive Assistant supporting the board. So just one action arising, which is on page 20 of the pack, which is to invite Healthwatch to a future board workshop, and noted that that is on the workshop agenda for December this year. So thank you, Lucy, for arranging that. So moving on, as part of the group structure, colleagues will know that Glenn Burley is our Chief Executive across the group. As he's not here today, Jane, what would you like to pull out of the Chief Executive's report for us?
Thank you, and always grateful that when Glenn's not here, he continues to write his report, because some of the things in there relate to all 4 trusts in the group. So his first point, he sets out sort of the complex financial regime arrangements that we're under, which is sort of linked between deficits, incentives, accountabilities, and under the current regime, how that affects the different members of the group differentially. So for us, because we've got a deficit plan, a £31 million deficit plan, that means that we've been penalised with a reduction in our capital allocation of around £600,000. But equally, we benefited at the end of last year from the capital incentive of around £2 million, which was around our ED performance in March. So I think Glenn's final point is important, which is that financial regime is due for an overhaul, and he's going to seek to influence this with the new government, whoever they are. His second and related point, which also features in my report when I introduced the performance report, is that link between the overheated urgent care system and the ability to fund additional capacity and manage that demand. And so it's that link again relates back to the financial regime, and it's quite difficult to fund additional emergency demand in the regime that we've currently got. And his last point is around the pathology and the developing pathology network. Now the new pathology network really does provide us with an opportunity to develop more resilience to our pathology teams, which are generally for each subspecialty are quite small. But as we negotiate the terms of that network, we need to really retain the flexibility and ownership that we have with our current teams and the way that we currently work. And that was absolutely demonstrated with our recent technical difficulties where the system that links our pathology network to our pathology system to our other systems had a technical failure, which meant that we had to resort to paper-based systems for 4 days. And actually that ownership of the team critically important in terms of making sure that we were able to keep patients safe during that time. So I think it sort of just makes the point more really that it's important that as part of the new network arrangements, we absolutely have to maintain that local ownership. And then the last is the usual clinical support division this month, which is providing an update on some of the great things that are going on.
Thank you, Jane, and agree there really are some great things happening in clinical support. Any questions or comments for Jane on Glenn's report? No, thank you. So again, we second your thanks to Glenn for his continued leadership with that, and our congratulations and thanks to the team who supported that system failure. And as always, there will be learning that we will then cascade in anticipation of any future similar outages in the future. And referring back to this morning, one of the topics that we were discussing was our emergency preparedness, and we have some real life coping with unforeseen circumstances and how we operate a business continuity plan. So some very recent learning in that regard. Thank you. Right, so moving on to the integrated performance report. Jane, what would you like to highlight by way of introduction?
Thank you. So just linking some of the things that are going to come later. So I'll start off really with those two related concerns, which were also in Glenn's report. So it's the continued pressure on our urgent care pathways and the link of that into our financial position. So we've continued to have to board, which means patients on wards who are outside our normal bed base, so an extra patient in bay, for example. So we've continued to do that through May and June, and now into July we are still in that position. And also our emergency department has stayed congested, so most mornings we're coming into at least double-digit figures of patients who are waiting for a bed. So the quality impact of that for our patients and the impact on our staff, I think we just need to maintain our focus on that. And so an awful lot of the work that we're doing at the moment is really trying to improve that urgent care pathway. But that's not just in the trust, that's right across the whole system. So that's from whether that's referral from GPs, whether that's working with the ambulance trust, whether that's working with the local authority on discharge delays, which have improved quite a lot actually. We've got improvement plans in place right across that pathway, and we're going to keep working really hard on those over the course of the summer, so we're in the best position we can possibly be in before we get to winter. And as I say, there is a link between that and having to staff all of those additional areas and the financial position, which I'll come on to. On Monday next week, we open our elective surgical hub, which is an absolutely fantastic, I went round it last week, absolutely fantastic state-of-the-art new facility. So it's 3 new theatres, and it's been designed by our clinical teams, by our teams working in theatres, to be the environment where we can do really highly productive work, so we can get as many patients through those theatre sessions as we possibly can in a safe way, but also a way that's a really good patient experience as well. So that does give us the opportunity, we think, to outperform the plan that we put in place for what we're going to deliver in elective pathways and our inpatient and day case patients this year. So that does give us more of an opportunity, we think, than we thought at the beginning of the year to attract more income into that, which will help with our financial position as well. So so just coming to that then, so our financial position is 1.2 million averse to plan at month 2. So something that is on all of our minds, and we are concerned about. It's driven really by under delivery of our cost and productivity improvement plans, and particularly overspends on temporary staffing and non-pay as well. So and just to point out a typo in the report, I put my expectation is that by month 4, but of course we're already in month 4. My expectation is by month 5 we will have an improved run rate, and I would expect that we have a plan in place to deliver our cost and productivity improvement target. That there will clearly be some risk in that, but in terms of the plans being in place, I'm expecting that to be in place by month 5. So a couple of positive things to end on. So our cancer performance in May has met our end of year targets. Obviously we have to sustain that throughout the whole year, but they have been improving over time, and a sense that they are sustainable. So that is really good news for patients. And again, our continued really good performance on recruitment and retention. We have from the 1st of July reverted nearly all of our Agenda for Change staff onto Agenda for Change terms and conditions. We had a whole range of different arrangements in place which have been put in there over the years to manage recruitment and retention difficulties. So we're moving everybody back onto the national contract, and a lot of that happened on the 1st of July. There's a few exceptions to roll out before the end of the year. And then the last thing is, I said about it before in terms of our Apex system going down, but just to record some individual thanks. So Andy, our coup, was on annual leave, so thank you very much to John Barnes for stepping in and leading the response to that, and also Jonathan Bolter, who's one of our associate coups, who was on call as well, and between them they managed incredibly effectively. But they managed really effectively because we had fantastic staff in pathology who came in off their annual leave, came in off their days off to double run, so that while we lost our electronic being able to order tests and get results back, it was all reverted to paper, and they managed to do all of the urgent tests with really good turnaround times. It was absolutely going the extra mile, so it's just an absolutely outstanding effort. So I want to put my thanks on record to all of those people.
Thank you, Jane, and add thanks from the whole board with that regard. We do recognise people as going the extra mile, and here is a very real and live example. And congratulations to Andy for booking his annual leave so effectively. So, any questions or comments for Jane on the introduction, or we'll move straight into the specific items? Thank you. Okay, so moving first to the quality section. Chizu, Lucy, what would you like to pull out?
Straight up to Chizu, Francis, thank you.
So I'll start. So with venous thromboembolism is when you have a blood clot in the veins. The national standard is that all patients who are aged more than 16 years should have a risk assessment on admission. And this should apply to more than 95% of admissions. So that's the target. We have struggled as an organization to meet this target. So we now have an improvement plan, which includes, amongst other things, having live dashboards with compliance percentages, so that clinicians, ward managers, etc., will be able to identify quite quickly who needs a risk assessment. It also includes a plan to link this risk assessment to our electronic prescribing, because typically our clinicians are better at prescribing than doing the risk assessment, so there will be alerts to remind them. But we're also going to be launching awareness campaign, education, training. And we've revamped the thrombosis committee under the leadership of the Deputy Chief Medical Officer, who will be leading this work. And we will be monitoring improvements through the quality committee. So do we have any questions, so I can move on to mortality?
Anything you think's particular on VTE? No, I think just from me, Chizo, welcome your focus on it. It is an incredibly important area for us to concentrate on, and would like detailed updates next month in terms of how quickly we're anticipating a change in that, because we know, don't we, that there's an enormous amount of evidence elsewhere about how other people are managing to deliver this target. So grateful for your and Tom Morgan-Jones's leadership with this. Thank you.
Thank you. So moving on to our mortality, the mortality indices SHIMI, which is a 12-month rolling data. The most recent that we have is between January 2023 to December 2023. So it hasn't really refreshed at time of going to press from last month. So it's still at 101.7. The HES data you have in your pack is 99, but HES data is always less than the SHIMI, which is published on NHS digital platform, so which is the one we're looking at. Some positive news. If you look at our mortality outliers that we have been tracking, we've had improvement in the SHIMI for heart failure and fractured neck or femur. Fractured neck or femur is still higher than where we would like it at 125, but it's a significant improvement. So we're still making a lot of effort to ensure that when patients present in ED, we can get them onto the wards in less than 4 hours. So trying to work on ensuring that we ring fence the beds for fractured neck or femur. We have had some increase in the SHIMI for stroke, although it's still within the expected range at 106. So we are auditing the deaths of patients who've presented to stroke to us in the last 5 months, and the mortality rate following that audit is 6%, which is much lower than national average. We're doing more deep dive, which we'll present at next board. We've also met with our public health colleagues to review mortality, stroke mortality in the community, to try and understand what that data is telling us and what we need to do to prevent the number of people developing strokes, and also their outcomes in the community before they come to hospitals, so earlier recognition. Our medical examiner system continues to work extremely well. They scrutinize 100% of all deaths in hospital and are now scrutinizing deaths in the community, with the aim that by September, all deaths in the community will also be scrutinized because it would be mandatory. And we've now embedded the Learning for Deaths committee, where we do the deep dives, trying to understand what the data is telling us and what lessons we need to learn and how we share that widely across the organisation. Thank you.
Thank you very much, Chizo. Any questions for Chizo or indeed for Lucy on any items in the quality section? No. Only one more comment from me, and that's you glossed over the headline at the front, which is the fact that Safety and Sync has been shortlisted for a Health Service Journal Patient Safety Award, which for colleagues who aren't aware of it, we like to think we're unique. Time will tell when we get to the award as to how much the national team think we are, but it is an incredibly innovative and important area where we, with our One Herefordshire partners and the ICB, meet together to talk about stuff that we do together, because patients are frankly bemused by the separation of organisations. Patients don't think in organisational terms, they think about pathways of care and who else is supporting them with their lives. So being able to look at patient experience across the pathway and making sure that we are collectively doing everything we can to improve the quality and safety of our services is really important. And so particular thanks to Lucy and Nikki Marriott, who until recently was the Director of Nursing for Herefordshire General Practice, very ably supported by Natasha Owen, for getting this off the ground and up and running, because it is a very dynamic and important open free discussion. Ian.
Yeah, sorry, Chair, I almost missed my in there. I was waiting for the kind of sections to come around. It was a question about the flow section on the quality report, which obviously spills over into Andy's report as well afterwards. And clearly we've done a lot of good work in terms of improving discharge rates and helping patients get home again and to where they need to be when they need to leave hospital, and focus is shifting to the front door now. And I was just interested in the comment about improving access to GP out of hours service, which I know will be of particular interest to any members of the public. And if you wanted to say any more about what we're doing in that regard, or is that a question for Andy in the
Andy, do you want to pick it up now?
Yeah, sure. Yeah, we're working really closely with Taurus, our local GP federation, in terms of their ring fencing out of our slots for our ED colleagues to screen patients directly to appropriate Taurus slots and appropriate patients at reception. So it's part of our ongoing development work, it's part of our valuing patients' time. And each weekend now we're seeing an increased use of those slots, as well as transferring that information digitally rather than over the phone. So each weekend now we're seeing the increased usage of streaming appropriate patients at the very front door in ED to out of our slots, which obviously allows reduced congestion in our ED and allows our ED colleagues to focus on more serious conditions that present to our ED. So ongoing work, but an absolutely key initiative ahead of the winter period.
Thanks, Andy. Jane.
Thanks, Andy.
Yeah, and I just add one more thing to that, because I think it's also really important that the public understand where they can and where they should access urgent care. And I think generally in Herefordshire, I mean, each practice is different, but generally in Herefordshire there is good access to primary care. But I think sometimes the stories in the national media overtake that and people think that they won't be able to access a GP appointment, and we have seen a really big rise in attendances to ED. So the other effect of this, other than using the funded capacity that's already out there really well, is that it does something towards educating patients. They come to ED and say, actually, we've got a GP for you to see, and this is where you need to go, and there's a slot available for you in an hour's time. So I think that's the other benefit, is just making sure that the public understand a little bit more where they should be accessing urgent care and what they should be going to primary care for and not coming to ED.
Thanks, Jane. Yeah, and a reminder, primary care, individuals' responsibility to look after themselves and have everyday type medicines at home. Obviously, lots of opportunities for support from community pharmacy, dentists at general practice, and NHS 111. So accident and emergency, and you'll have heard Jane refer to it as ED. The emergency department is for emergencies, and we do encourage people to think before they arrive at a specialist service if there are other ways that they can look after their health and well-being. Grace.
Thank you. Just building on that and just acknowledging, I know, having spoken to a lot of other chronically ill patients and people with difficult conditions, a lot of people sometimes will end up coming to A&E because everybody's, scared and distressed and obviously hurting in some fashion. And often there's a sense that at least in A&E, the doors will be open, the lights will be on, humans will be there, and you won't die alone there because you will be with somebody. However, given the difficulty and the strain on the systems, whereas that perhaps, a few years ago that used to be much, much more true, still was difficult then. At these days, I think, we really do need to look at what is the most accurate and effective route for us to go down. Otherwise, we could end up sitting, much longer and waiting for treatment that we could get much rapidly elsewhere. So, I speak to people, they say, well, they'll send me to A&E anyway. I'm saying that's less and less and less true. If we want to get the care, we need to pick the right route to do it, as hard as that can be sometimes. And this kind of things you're saying, it helps people to make those choices. Thank you.
Thank you, Grace, very much. Right, let's move on. Andy, much of what you would have said, I'm sure, has been picked up by Jane or in the other discussions. So what particularly would you like to pick out in terms of activity and performance?
Thank you, Francis. Yeah, just a couple of things from me. I'll take my report as read. Just one thing I did miss in my report is we've obviously been through another period of industrial action from the 27th of June, which ended on Tuesday morning, just gone on the 2nd of June at 7 o'clock. 5 days of industrial action. Just want to express my thanks to operational and clinical teams. Unfortunately, it's become a well-oiled machine now, but a distraction in terms of our teams could do, a distraction our teams could do without in terms of their other priorities in delivering, as Jane's already mentioned, urgent care and our elective waiting list issues. So well-oiled machine. Thank you for operational colleagues. Unfortunately, over the period, we did continue to see high levels of ED attendances, and unfortunately, and I apologise to those patients, we did cancel 11 day case procedures and 130 outpatient procedures over those days. So sorry to those patients that were affected, and we will endeavour to get those patients rescheduled as soon as possible. James already mentioned the second point, the ongoing issues with boarding patients on ward, opening up the volume of escalation beds we've got open over our acute and our community sites. But our urgent emergency care levels of performance for our 4-hour emergency access standards has remained positive since we've done our test to change month back in March. That improvement has remained broadly the same and slightly more improved actually in May, and the same levels in June. Particularly significant improvements in our minors performance, our paediatric performance, and a reduction in our non-admitted weights as well. So some real improvements are seen in our ED, and as already Jane alluded to, it's a system-wide issue, and there's various pieces of work going on internally and externally, including right-sizing our medical beds, improvements to our D2A pathways, and relaunching and expanding our virtual ward, which I've mentioned in my report. Just also want to echo Jane's comments around our cancer performance. We achieved the faster diagnosis standard and the current 62-day standards for May. It looks like we've also delivered that for June, but also improved that 62-day standard further in June. So well done to our teams, and that's a really important target for us to ensure we deliver and improve on. And then our elective activity for May has remained ahead of plan, both for May and year to date, but also for June as well. We were ahead of our plan, our activity plan, but also ahead of 19-20 pre-pandemic levels. We just need to ensure now that that is delivered at the agreed cost or lower, as Jane has already alluded to. Our value-weighted activity, which is the way we measure our activity, not just patient numbers, but the complexity, is also back performing high and is one of the top performers in the region. And we're delivering, on average, over the last 4 weeks up to mid-June, 117.5% value-weighted activity compared to 19-20. So again, despite all the challenges that we've got on our urgent care pathway, our elective pathway continues to perform really well. And like Jane, I'm really excited, and I know colleagues are across the trust, for our opening of our elective surgical hub on Monday, a game changer for the patients of Powys and Herefordshire.
Thank you very much, Andy. Any further questions for Andy on any of those performance issues? No, very comprehensive. Keep it up. Thank you to you and your teams. And yeah, we are very excited to have the report next time about the impact of the new elective surgical hub. Jeffrey, what would you like to pick out in terms of our workforce?
Yeah, thanks, Francis. Well, as you can see within my report, we are maintaining good performance on most of the workforce key performance indicators, and we're taking active steps to reduce sickness absence. So we're going to be focusing on those with high short-term absence and those who've been absent for over 100 days, just to ensure that we have the right support and the right management interventions in place for those individuals. Working with ICS-wide colleagues on a new culture and inclusion strategy, we are taking steps as part of that strategy to address health inequalities, to enhance the employee experience, and also to strengthen the freedom to speak up culture across organizations within the ICS. So those are the key 3 aspects of that new strategy. We are supporting the drive for efficiency and productivity. We have a workforce opportunities group in place. And as Jane mentioned earlier, we're taking steps to terminate some long-standing local pay arrangements, which were not in line with national terms and conditions. So we're driving that to try and be more efficient and productive. And finally, from our perspective, our Family Fun Day in partnership with Halo Leisure takes place this Saturday, and we're going to be pushing forward our health and well-being programs at that event, and all members of the Trust Board are welcome to attend if they can do so. Those are the key highlights I wanted to pull out, Francis. Happy to take any questions.
Thank you, Jeffrey. Any questions or comments for Jeffrey? No, well, I know Jane is off on holiday. I don't know whether that's before or after you've leapt about with the fun day. It sounds exactly your sort of thing. I'm delighted that Lucy's back fighting fit, because I'm sure that you will want to set the bar high in terms of energy expended. So some really good stuff, and we absolutely want to support a culture where we enable our staff to be as well and happy as they possibly can. This time of year, we would hope that our sickness absence level would be as low as it possibly can be, and so very grateful for your leadership and support from all our teams to do everything we can to help people to be at work. So thank you for that. Okay, Katie, what would you like to pull out in terms of the financial performance?
Thank you, Francis, and I'll just build on Jane's comments earlier in terms of the introduction. So as we've described, we have an adverse variance to plan at minute 2 of £1.2 million. So that means we have a year-to-date deficit of £7.1 million overall as part of our financial plan, which is a revised deficit of £31.4 million for the year, which we touched on at last board. In terms of some key elements of that, so on pay, we spent £900,000 more than we planned to, which, as Jane alluded to, it relates to our continued reliance on temporary workforce and some of that slower than anticipated delivery of our cost savings programme. In terms of agency spend overall, it was around 6% of the pay bill in the month, but pleasingly we are seeing that significant reduction in off-framework usage through the first few months of the year, and that of course is aligned to the national policy around implementing a cessation of use of off-framework agencies from July, so we're well placed in that regard. Despite some of those urgent care pressures that Andy's described, and he's also touched on, us, we've been able to maintain strong elective performance through the first few months of the year, and that has meant that we've generated additional income of around £600,000 to date, which has helped to partly mitigate some of those higher than anticipated costs on the expenditure side. And what we're worried about from a capital perspective is our overall allocation. So it was small to start with for the financial year, given the range of challenges that we need to address. And as a result of the overall planned deficit from the system perspective, allocation has been further reduced, which was covered in Glenn's report, by around £600,000. So we've got a really constrained capital position, which is requiring really close management and some quite difficult decision making around balancing our risks within that limited funding available. In terms of cash, that's clearly a risk with a deficit plan, and we continue to closely monitor and manage our cash position. And just a reminder for board colleagues that that cash support from NHS England, in line with the deficit, is only available up until the level of that planned deficit, so £31.4 million, and then any cash to support the capital programme. But where we have an adverse variance, that isn't cash backed, and we are expected to manage that ourselves. So it's really important that we're able to bring that overall financial position in on plan over the course of the year. That was all I wanted to draw out today, Francis, but happy to take any queries.
Thank you, Katie. It's absolutely not the position we want to be in at this point, but grateful for your candour and very clear explanation of the reasons. Questions or comments for Katie on the financial situation? So a couple of comments from me, if I may. None of the board underestimate the operational pressure that we've heard about and the ambition to treat more people and provide the best care that we can. But we have, as an organisation, got to regain the financial grip that seems to be slipping slightly, and the longer it goes on, the harder that becomes, which you all know. So thank you, Jane, for your comment about expecting by month 5 to have a clear plan for that. I think it's also worth everybody remembering that our freedoms as an organisation and our ability to have opportunities like building a new elective surgical hub and some of the things about diagnostics are very much predicated on our effectiveness as an organisation and being seen as an organisation that will deliver on our collective responsibilities to the taxman. So it is in all of our interests to demonstrate our ability to get the numbers back under control. None of us underestimate the size of the challenge, and Jane said, you know, our plan of just over £31 million deficit is an enormous figure. Colleagues who are aware of the history of Wye Valley will know that lots of that is a structural deficit based on our rurality, and there are ongoing discussions about that. But we have to demonstrate our commitment to live within the resources that we have at our disposal. So anything the board can do to support the executive team, we absolutely will do so. Okay, let's move on. We're now moving into items for approval. So Katie, the digital strategy.
Thank you. So back with me again. So I'm really pleased to bring forward the digital strategy refresh. So it builds on the previous strategy that was developed in 2020, and this would cover the period 2024 to 2027. So it's intended as a bit of an organic development from what we'd already had rather than a step change. And as you'd expect, it's been in development for some time in consultation and collaboration with key stakeholders, both internally and externally, including Hoople as our delivery partner and our ICS partners as well. And as a board, we held a workshop last year as part of its development, and it's been endorsed through our trust management board. So a really big thank you to all colleagues across those partners who've been engaged in its development. The strategy is built around 4 key areas for us, so clinical systems, back office and infrastructure, citizen access and benefits realisation. And at its core, the strategy really is intended to help us to select, deploy and run technology to help the organisation achieve its objectives. So how do we use our digital tools to enhance what we do, increase efficiency and improve patient experience? It's of course underpinned by a governance framework to make sure that we've got robust plans to deliver those strategies. And the delivery of the strategy remains iterative in terms of aligning our digital capability and our digital maturity with the needs of the organisation and our operational ambitions. In terms of that next 3-year period then, so it's appropriate that it's characterised by a bit of a taking stock of what we've already delivered over our digital journey. How do we optimise what we've already got to make sure it's working as effectively as it can and we're realising those benefits? How do we broaden its internal appeal? How do we make it as user-friendly as we can for our clinical teams on the front line and our workforce and our public reach in terms of how do we make use our digital tools to better engage with our patients and our population? It's presented today to the board for approval and adoption. So that would be my ask to board colleagues, please.
Thank you, Katie. Yeah, it's been through lots and lots of stages, and this is the final rubber stamp of approval subject to colleagues. Any further comments or questions for Katie and the team? Jane?
Not a question, it was just, I mean, we covered some of this in our workshop this morning when we were talking about the future of digital, and it's just, really, I think as part of this next phase, it really is about driving the benefits from it, particularly driving productivity, and that may mean supporting some staff to adopt new technologies at a greater pace than they perhaps would want to. But as long as the technology is proven, we've got other teams using it, and we've got proven benefits, we need to really make sure that we are supporting all of our staff to adopt the technologies so that we do get the productivity benefits that we expect out of this very large investment that we've made.
Yeah, absolutely. Thank you. Ian? You're still on mute, Ian.
Sorry, I switched my hand off, but not the not the mute. It's a thought and observation about patient and citizen communication, I guess, given that that's kind of one of our 4 kind of building blocks, really. And for consideration, is there more that we can do to promote what we're doing digitally, and as it were, to kind of get people ready for the fact that digital uses of access, etc., will become kind of more to the fore? It's almost kind of encouraging and signalling that is what our intention is. So it's just something I think to keep in the front of our minds in terms of patient and citizen communication, actually, to keep that digital message strong.
Thanks, Ian. Absolutely part of one of the key tenets of our strategy, and what links really closely with some of the work we're doing with partners across the ICS around that digital inclusion and communications with our residents.
Thank you. So, as requested, the board is asked to adopt the 24-27 digital strategy. If any board members do not want to do that, will you please raise a digital hand? Duly passed, approved. Thank you, Katie, and please pass on our thanks to the team for all of their hard work. Okay, let's move on then. The next item is an update on the integrated care system and One Herefordshire work. Jane.
I'll pass it very quickly on to John after sort of the huge flurry of activity at the end of the year in terms of planning and getting all of those plans together and submitted across the ICS, with really not much to say this month from an ICS point of view. But John and I really wanted to highlight the work that's been going on with the BCF. This is, you know, it's been in place for us for a number of months now, and we're making some real progress, and there's lots more to come. So I'll pass over to John, who's leading on the work.
Okay.
Yeah, thank you. I'll just take us through the paper really quickly. Just try to provide a bit of background, and just for sort of a read through, really, to describe what the Better Care Fund is for those that don't know. Many of us will know it more than we used to. The MOU, which is probably the most important part of this, it's changed our relationship as an organisation with the BCF, but also changed 1HP's relationship with that, where we now work as a collective on designing and delivering of those BCF schemes, and in particular, I suppose, to the fore of that really for us is discharge to assess services. That was been such a problem in terms of patient flow and getting people home or to the best appropriate place following their hospital stay. So again, I've just set out our roles within the MOU because that's really important. BCF planning this year has been quite difficult. We did it together, as myself, commissioning and social care colleagues, planned this together, working with providers as well. And whilst there was a significant uplift in funding, there was a significant downlift in available money. So it nets off to only £300,000 more, which essentially inflation will have eaten up. That's because we used reserves last year and a one-off grant as well, of circa £500,000, I think. So we had lots of non-recurring money last year, which we used to provide the care to large numbers of people on spot purchase, accommodation or support at home. And so this year, effectively, the big uplift wasn't there. So we ended up with cost pressure on discharge to assess services, but we've worked together. We've looked at length of stay and how that benchmarks compared to others. We've looked at occupancy levels and created an ambition around them. So if we can get a length of stay improvement and an occupancy improvement in our main three providers of D2A, then we can deliver within there. So that's what we're going to do. That's the plan. It does set it out in quite some detail there. I thought for the record it was useful to put in there, but I don't intend to go through that now unless people really want to. So that roughly is where we've got to on the plan. We've all agreed that we're working with our providers, and I should emphasise that it doesn't mean the providers have to improve. It means that as a system we have to improve the way we use those beds. So that's Y Valley, that's social care, that's commissioning, that's brokerage, that's the providers themselves. All need to change a little bit the way they do things to make that pathway much more readily accessible, and to get people back home when we can out of the bed as soon as possible, rather than 6 weeks reablement period, which is a maximum, not a minimum. Many systems have an average 4-week length of stay on reablement pathway, as 6 weeks. And that's because I think people time out. So there's work to do for all of us, and we are doing that work, and there's a very capable action plan. Should mention the governance as well. I'll make a few notes there around D2A board. That's really important. We're starting to see things come through. It's integrated care executive, which Francis chairs, but hopefully we'll start to see some more structured data coming through now as we've employed an analyst and we've got a dashboard in production. And finally, I just talk through a little bit about what we've achieved. I have to, and I've done this in many places, we have to acknowledge the fantastic work that our commissioners have done within the council in terms of pathway, domiciliary care market within Herefordshire. There were over 150 people in various settings waiting for domiciliary care 12 months ago. That might be at home, that might be in a reablement bed, that might be in hospital. That now is often single figures, and consistently so. It's not a sudden improvement that's going to deteriorate. And there's been a a complete shift in the way domiciliary care is provided in Herefordshire, and that's really is fantastic progress. So all credit to those, and I can't credit them enough. So there's other progress. We've got the governance in place. We have seen a huge shift, partly as a result of that domiciliary care, partly as a result of the work we're doing with providers. In terms of, we think our average length of wait now for pathway 1, which is support at home, is probably 1 to 1.5 days. We're just trying to work through the evidence to get that. It was 4.5 days 6 months ago, and that's a big difference. There are some other things we're looking at. Yeah, and I suppose the other big one thing is we've got an agreed plan in June as opposed to December when we agreed it last year. So we are a good solid 6 months quicker this year in terms of getting to a plan and start focus on it. So real progress, but lots of things to come as we now fully understand this. And the final thing, I suppose, is that ICE will be reviewing all of the services, and I think Francis has got a meeting coming up in the next, sometime later in July, I believe, to review all the services, not just the D2A stuff, but that is the sort of the sort of shark closest to our boat at the moment in terms of making sure we have a credible plan. So thank you.
Thank you, John. Any questions or comments for John? No, thank you. For those people who haven't been involved in it, the Better Care Fund is a joint bank account, so you don't argue about who needs to pay, you just say this is about the money and this is the need and how do we work jointly on that. And yeah, big thanks to everybody who is being very creative and committed to making waits as short as possible for people, the absolute essence of valuing patients' time, but also how do we avoid people becoming patients in the first place by helping them to be well. So good, thank you very much. Right, let's move on. Medical agency reduction programme, Chizo.
Yes, thank you. So the aim of the medical agency reduction programme is to maximise our resources and improve productivity and efficiency. So a key performance indicator is the amount of medical temporary staffing we use. So if you look at the graph, we have had some success in this area. We've had 34% reduction in medical agency use when compared to the same time last year. But when we look at that medical bank use is about the same as last year. So what we're doing about that is we are increasing our medical establishment to match what we feel that we actually need so as to reduce the use of banks. And we're also applying more governance, grip and control. So standardizing the rates that we pay for shifts rather than having so many negotiated rates. We're also improving our recruitment. And we have been successful in converting some locums into our bank. And in some instances, like yesterday, we're able to convert a locum into a permanent appointment, which is what we want to do. So there is still lots of work to do, but we are, I think we're in a better place now than we were at the beginning of the year.
Thank you, Chizo. Any questions or comments for Chizo? No, thank you. Keep up the good work. And one of the other topics we were discussing this morning was about job planning. There's a particular structure nationally agreed with our medical colleagues about ensuring that people understand the amount of work and the distribution of their clinical activities across the year and how that can avoid us needing to have short-term locums to cover some things. So some really important work to make sure that we are being anticipatory and having a prospective job plan rather than reacting to things. So thank you for that. Lucy, the Nurse Agency Reduction Programme.
Certainly, thank you, Chair. So lots of detail in the report. I guess I want to talk about three things, which is the money, agency provision and our workforce, so our employed workforce. So just in terms of the money and the headlines from the report, just to go back a year, if I may, we spent £5 million less last year than in the previous year. And we've set ourselves an ambitious target to spend £4 million less this year than last year. What that means in real terms is that we can spend no more than £5.3 million on agency in the full year. And whilst our month 1 and 2 performance is really strong, and actually it's the best performance that we've had in at least the last 12 months, it's not where we need to be. So if we're not going to spend any more than £5.3 million on agency in this financial year, we need to be spending no more than £450,000 per month. And in month 1 and 2, we spent £620,000. So there is still more work to do. Well, how are we going to achieve that? We achieve that through our employed workforce. And you've heard Jeffrey allude to earlier, we've got really strong performance overall. So our vacancy position's improving, our sickness position, our sickness management's improving, but we have got some hotspots. So for nurses, we're in a really strong position. Our vacancy position is the best it's ever been in the 8 years that I've been the chief nurse at Wye Valley. For registered nurses, and our sickness position for that workforce group is also sort of nearly in line with the sort of national best performance. However, for healthcare assistants, we have got a deteriorating vacancy position, and we have got a sickness position sort of bobbling around 8, 9, 10%, which is way above where we need it to be. So target our efforts there. We can reduce our reliance on temporary workforce and therefore get down to that level of spend and that ambitious target that we've set ourselves. And then just a little bit in terms of agency provision and performance. We have a master vendor contract. They're performing really well. The detail of that is in the report. That contract is due for a review in September, and we're working to consider our options moving forward. Happy to take any questions, Chair.
Thank you very much, Lucy. Any questions or comments for Lucy? So it's a well done for what you've done. Absolutely hear your ambition to get us to where we need to be, and you have all of our support to do that. And I know that your senior nurse team are very committed to doing everything they can. Jane.
Yeah, just one question in terms of that reducing the number of vacancies for healthcare assistants. What's the trajectory on that? When do we think we're going to be down to very low numbers of vacancies again? That might be you, it might be Jeffrey.
It might be a combination of both. I'll talk about what we've done to get on top of that. So we've reintroduced centralised recruitment, which we have disbanded when our vacancy position improved previously. So we've reintroduced that. We're on to fortnightly recruitment instead of monthly. And we're just reviewing sort of, it's not only the recruitment end of that, but also the induction capacity that we have to support individuals. We'll expand that induction capacity, as I say, increase our recruitment processes to twice a month. We don't have a final figure in terms of trajectory, Jane, just because we're just doing some of those adjustments in terms of the areas that had investment, and therefore what does that look like overall, but we could certainly have that by next month, Jane.
Thank you both very much. Okay, let's move on. The next item is the perinatal safety report, and I can see that Amy has joined us. Welcome, Amy. Just before you start, I'd like to make the board aware that there is a national requirement for NHS trusts that provide maternity and neonatal services to have board level safety champions. You will know that Lucy is the executive safety champion and I am the non-executive safety champion. To ensure we provide as much support to Amy and colleagues as we can and bring that assurance and scrutiny with a new pair, an independent pair of eyes, and delighted that Sharon Hill, who's one of our other non-executive directors, is going to be sharing that non-executive safety champion role with me. So we will hopefully be able to ensure that we are available to provide that support and scrutiny as much as possible. So thank you, Sharon. Sharon joined us just over a year ago and has spent the last year learning the NHS language and all of the acronyms. Welcome to maternity services, where there's another whole set of things for you to learn. So every day is a school day, as they say. So Amy, we've received your report. Thank you very much. What particular would you like to pull out for the board's information?
Thank you very much, Frances. So just to highlight that this report contains data from May and has already been presented to a quality committee, where it has full oversight and assurance of the data contained within the report. There aren't any areas of escalation or points of significance that I deem to need further discussion in the performance section, but we did just want to highlight and reiterate, I think, on the back of your points, Francis, the minimum data set that is required to be shared contains sensitive and detailed information in a small trust with 1,650 births. This does mean that is reported to the private section of board to preserve the dignity and reduce any potential identifiers to our women and families who use our service. However, assurance should be taken that this has been scrutinised already, as said, at Quality Committee. Just as an overview, the workforce staffing is in a positive position. You will see that we provide details of the maternity workforce, and this is a new template and a new mechanism of reporting in terms of the acuity tool. Acuity was met 85% of the time for midwifery staffing, with 13% of the time being slightly short and 2% a little bit more than we'd like in terms of our numbers, but each of those times appropriate mitigations put in place to retain safety within the service, all appropriate, and we see that this demonstrates flexibility to meet the acuity needs, so we don't see this to be of any concern. You'll see that we recruited a locum to cover some sickness. This may be extended if possible, but I think our obstetric team are just getting back on track now with people returning to work, which is positive, and the anaesthetic workforce is stable and doesn't reflect any areas of concern. In terms of training, we're on track with our training for the CNST standards. I would just like to highlight, I think members who have read the paper will pick out that our training compliance for maternity support workers is less than 90%, currently sitting at 67%. For assurance purposes, just to note that previously maternity support workers weren't included in the essential people to be trained. However, we are fortunate that this has been recognised nationally, in that their roles are crucial, particularly in emergency situations where they play a vital role, and as such they've been invited to participate in training. In order to meet the time frame last year, we did have they were sort of bunched up a little bit, which means that they all fell off around about the same time, but we're on a trajectory to meet the 90%, so it's not of concern, and we ask board to be assured by our trajectories. Our compliance with saving babies' lives hasn't changed significantly since the last time that we presented at board. It is required to be included, but it's a quarterly oversight by the LMNS, so there isn't an update in this particular paper, and you will see that there is a section which highlights the safety champion work that is undertaken, but again there is lots of assurance, and any points have been addressed within the report. Thank you.
Thank you, Amy. Any questions or comments for Amy? No, thank you very much indeed, and look forward to seeing you next month, but we'll no doubt see you in the interim. Thank you for that. Do stay, but I'm sure you've got other things you want to do. Excuse me. Okay, so moving on, the next item is an update on the Guardian of Safe Working. Chizo.
Yes, thank you. So the aim of the role of the Guardian of Safe Working is to ensure that any issues with compliance with safe working or rotas that affect doctors in training are addressed. So we appointed a new Guardian of Safe Working lead early this March, who is one of our specialist doctors, Dr. Lecky. In the last quarter, there were 14 exceptions, which he dealt with the educational supervisors and the doctors, and 11 are closed, and we are on trajectory to close the other 3. You can see from the table that most of the issues are related to working hours, and they all relate to medical division. So we have try to address them with the clinical leads, but we are looking at work which also maps to the map in terms of making sure that we're right sizing our medical establishment, and also we're monitoring any trends, any particular hotspots to try and walk through, but there are nothing else to escalate to board.
Thank you. Reassuring. Any questions or comments to Chizo on that? Nope. Okay. The next item is the freedom to speak up, but I can't see that Joe has joined us yet. We are doing well on the agenda, so can I suggest we pause and go to the next item, and we'll come back to freedom to speak up when Joe Sanford joins us. So the next section of the agenda is the committee summary reports and minutes, and starting with the audit committee report. Nicola Twigg, who is our non-executive director who chairs the audit committee, isn't able to be here today, but I'm sure Katie or others would answer any questions if anybody has any questions or comments on the audit committee report. No. Then we are asked to receive it. We will duly receive it and follow up in due course. The next is the Quality Committee and from the minutes of the 25th of April. Ian, as chair of the Quality Committee, anything you would like to pick up for board?
No, there's nothing I want to add, Chair. There are a few points there pulled out in the covering report, and I'm happy to answer any questions. Thank
you very much, Ian. Any questions or comments for Ian on those minutes? No, obviously very clear, thank you. And yeah, as a reminder for colleagues who aren't available, we have a formal board committee structure that allows the board to go into issues in depth that would not be possible in the board as a whole, and it obviously enables us to have wider representation from our teams, and so the Quality Committee meets monthly. It's a good 3 hours of intense scrutiny and builds on work that is also overseen through the finance and performance executives that are led by Jane and the executive team. So don't want people to think that the only place that these things are scrutinised is through board. Quite to the contrary for that. Lou, do you know if Jo is able to join us?
Hi, thank you, Chair. Yes, she was asked to arrive at 2:05. So we're very early.
Well, three minutes. I think that's perfectly on time. Jeffrey.
I'm just going to say I've sent a message though, Francis, for her to join as soon as she can. Oh, there she is.
And here she is. Welcome, Jo. You may not be able to hear us quite yet.
Yeah, I can hear you now.
Welcome, Jo. We unusually are managing to be not just on time, but a couple of minutes ahead. So we can go straight into your report. I can't actually see you. I can see your name, but I can't see you. So I don't know whether your camera is working or not, but we can hear you. So
the camera's on, but
don't worry, we can hear you. That's the important thing, and you're with us. So we have received your report gratefully. Thank you very much. What would you like to bring particularly to the board's attention?
So I'll take my report as read. So I've taken a quote from NHS England that says that building a more open culture in which leadership encourages learning and improvement leads to safer care and treatment and an improved patient experience. I feel really very confident that here at Wye Valley Trust, speaking up is valued by senior leaders as seen as an opportunity to both learn and improve. Evidence reflecting this is noticeable in my report, showing that a 74% increase in cases over the last financial year. Once a case has been resolved, a link is sent to an anonymous survey where staff can feedback on the service they received. When asked if they would speak up again in the future, 98% replied yes, 2% maybe, and to date, nobody has said no. The National Guardian Office has produced a list of what they call warning signs that suggest a trust isn't promoting a positive and healthy speak-up culture. Having a high volume of cases does not appear anywhere on that list. Therefore, the increase in cases should be viewed in a positive manner and is a reflection of staff feeling heard and appreciated. As a trust, we're creating an environment where staff feel really safe to speak up. A contributing factor to this is the increased efficiency rate for achieving a resolution for each case. Just 3 weeks into this financial year, all of the previous year's cases were closed. Cases for Q1 of this year have already increased by 30% compared to the highest quarter of last year. In order for an efficient service to be maintained, I politely asked the board to consider investing in the role and the Speak Up service. This would be offset by savings made trust-wide. Feedback from staff using the service highlights that a fast resolution for cases significantly reduces sickness episodes, and that has either been by preventing those episodes altogether or by significantly shortening them. An email from a staff member was sent to some executives just last month and was very complimentary about their Speak Up service. They stated that before using the service, they were seeking employment outside of the trust. However, resolving their case so promptly has changed that, and they are now really happy to come into work, demonstrating that investment in the role by increasing the contracted hours will contribute to reducing sickness, improving staff retention, and generally leading to a wider cultural improvement. There are many barriers that prevent staff from speaking up, and it is an extensive list, but 2 of the most common ones include being a member of a minority group and a lack of confidence in the process. As the Guardian, I'm constantly striving to break down those barriers with my metaphorical hammer. Success of this is evident with a 78% increase in champions recruited this year, 15% of whom are now BAME staff, which was compared to 3% when I first took it on. And I also have a member from both the LGBTQ+ and disability awareness networks. Champions are both productive in creating and promoting awareness of speaking up and also dispelling any myths surrounding the service. And talking of myths, one of the most common ones I hear is that the execs will not listen and they're not supportive of speaking up. So with the help of John Burnett, I've produced a short promotional film demonstrating how supportive they are. There is Film Envy amongst other Guardians within the West Midlands network, and it's going to be shown at our annual conference in Hereford in October even, showing that Hereford or Wye Valley Trust is leading the way. If you haven't had a chance to view it yet, a link is available in my report. And then just finally, this year's been really very successful, but for the coming year, I've got no intention of cruising along on the back of that success. I intend to drive forward, striving for continuous improvement. I'll be evaluating all the feedback regarding the Speak Up process, and I will always endeavour to ensure that here at Wye Valley Trust, everyone's voice does matter. Thank you.
Well, thank you. That's quite a sales pitch, but absolutely well done. And we are so grateful for the enthusiasm with which you have taken on this role and the difference that you are making. Jane.
A few things, Jo. So first of all, thank you very much for your leadership and your energy on this. It's making a huge difference. The KPIs that you're talking about, it's a bit like instance, isn't it? We want to have a lot of freedom to speak up, concerns being raised, but the speed at which we're able to close them down and deal with those issues is also really important. So, and I guess there's going to be a ceiling for that. I don't know where that's going to be for us, but it's certainly a positive. I think that we're seeing more people speaking up. And the other thing that Jo didn't mention, she put on a lunch for the FTSE champions on Tuesday of this week, and a number of us attended that and had an opportunity to chat to some of the champions. And a few things out of that. One is they felt very well supported by Jo, and they also felt they were making a difference. And the last thing I'd add is what I was struck by with that group of champions was they were a wise and mature group of staff. They really understood the role, and they were universally excellent.
Thank you very much, Jane, for that. Ian.
Yes, just a couple of observations really to sort of underscore some of that. I'm the link NED for Freedom to Speak Up. So I provide non-executive director support to Joe, and myself and Joe and Jane meet quarterly to review where we are. And Joe's been doing this job now for a year. There was a bit of a handover at the beginning of last year, but I think it's the beginning of July when you started flying solo, as it were, Joe. And I do think we've made tremendous progress in the last 12 months. That's reflected, I think, in the number of inquiries that we're able to record. But actually the champions, I think, are a fantastic group of people, and I was at the lunch on Tuesday as well. We've gone from 20 something to over 100, and they're both a resource for people to contact who've got concerns, but actually they're also a fantastic network of people across the organisation promoting the whole idea of a speak up culture. And that, in my observation, is that's the biggest shift we've made in the last 12 months. We've actually gone from what was a good process to actually being able to promote the culture and people being aware of that. And actually a couple of the champions I spoke to on Tuesday actually said they weren't aware of Freedom to Speak Up actually before they'd seen some of the promotional things that Joe had done, and then on the back of that had actually become champions. So I think that's fantastic. Just my observation on where, in a sense, where do you go next with some of this? I think there probably are some issues about manager responses to some of this. A couple of people did say to me, the champions, that they'd maybe had a little bit of suspicion about what having a Freedom to Speak Up champion means in your team. So there's a bit of promotion education that we kind of need to continue to do with some of our team leaders and middle managers. But that's to take nothing away from the very positive work that Joe and others have done, the champions included, over the last 12 months.
Thank you, Ian, very much. Second, all of that. We want Y Valley to be the place where everybody can speak. It's not the people around this table who have a monopoly on knowing the difference between right and wrong and spotting when things aren't going well. We want every single member of staff to feel empowered to do that through whichever route. And although Joe is our nominated expert, I'm sure Jane would say that any member of the executive team have a metaphorical open door at all times if anybody has concerns that they want to raise. Any other questions or comments for Joe? Thank you very much indeed. I'm sorry we couldn't see you, but
I'm sorry too.
hopefully you can see us, and the number of people who are saying thank you very much for the enthusiasm, commitment, professionalism and integrity with which you've taken on this role. And we never dreamt you would rest on your laurels, Joe. So I'm delighted to hear that you're not going to. Thank you very much indeed for joining us. Thank you. Thank you. Okay, we're now on to any other business from any board members that they would like to raise today. No, thank you. So questions from members of the public. Jane, I think that just before we started, we did have some questions from Chris Lewandowski, who we know is a friend to the organisation and frequently shows an interest in our services. What did Chris say, and how would you like to respond?
Yeah, so the two issues that were raised, one is around his recent personal experience in ED, and actually I think we've covered the response to that. You know, as we've gone through this meeting, that none of us are satisfied with the quality of experience that we're able to give to patients in ED currently because of the congestion. So I think we've answered that question and didn't particularly want to go through the personal story in a public setting. The other question he raised was, which he's raised a number of times, is around the response to violence and aggression incidents for our staff. What Alan's going to do is contact Chris directly, because we think we've probably answered a few of those questions already. So Alan's just going to get in touch and just understand if there's an ongoing concern, and then we can bring that back. And so we feel that's the best way to respond to that, because we have talked about it, I think, 3 or 4 times in the past through the public questions.
Thank you, Jane. Yes, support that view. And if we could have, obviously, if there's anything significant, if you could brief the board as soon as possible on that, but otherwise an update in due course from Alan would be very helpful on that. So I don't think we've had any other questions or comments, have we, Lou?
No further comments, no.
Thank you very much. So again, for members of the public who may not have joined a public trust board before, one of the benefits of doing it this way is that people can view the board at their leisure, but we are very much aware that we are here on behalf of the public. So if there are things that you have a particular concern about, we ask you to raise that quickly. If there are more strategic or system-wide issues relating, then we are always interested in getting feedback and engagement from members of the public, and encourage you to do so. And the details for that will be on our website. So that comes to the end of this public section of our board meeting. We will adjourn and meet again shortly for matters that are confidential in nature and therefore for board only. And the next meeting of our board will be on the 5th of September at 1 o'clock, and look forward to seeing people there. Thank you very much. Colleagues, can I suggest we have a 10-minute break? So get back at 2:25 past 2 on the link for the private board. Thank you very much.